From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, my name is Dr. Melissa Simon, and I'm an associate editor for JAMA. In this JAMA podcast, we will be discussing the article by Dr. Rebecca Perkins and colleagues entitled Cervical Cancer Screening, a Review. We are joined today by Dr. Rebecca Perkins, a professor of obstetrics and gynecology at Boston University Chobanian and Nabedizian School of Medicine and Boston Medical Center. Thank you so much for joining us today, Dr. Perkins.
It is my great pleasure to be here. This is one of my favorite topics to talk about.
Wonderful. Why don't you start off with why now? Why do we need a review of cervical cancer screening?
So that is a great question. Cervical cancer screening is so important now because we are on the verge of a win. There's actually discussion around the world about elimination of cervical cancer as a public health problem. And what that means is we actually know what causes cervical cancer, which is human papillomavirus or HPV, and we have tools that can prevent essentially all cases. And those are HPV vaccines and HPV tests and other ways of doing cervical cancer screening and management.
Can you tell us a little more about HPV vaccination?
Absolutely. So the HPV vaccine is a tremendous success story. We started giving it in the US and around the world in 2006, and we're currently using a 9-valent vaccine, which means it prevents against the 7 most oncogenic or carcinogenic HPV types, and also 2 types that cause genital warts. And what we have seen is that not only do we have fewer infections, and fewer precancers, but we're actually starting to have data now that on a population level, young women who received the HPV vaccine in early adolescence and are now aging into their late 20s have almost a 90% reduced risk of developing cervical cancer. And the other consequence that I don't even think people were anticipating is in Australia, where the vaccination rates have been very high since the beginning, they're actually seeing reduced rates of preterm labor. And we know that HPV infection is actually associated with preterm labor and other pregnancy complications. And we're seeing that when you give the HPV vaccine and you don't have women in their 20s and early 30s having HPV infections, the rates of preterm labor have gone down. So that is something that was an unintended positive consequence of HPV vaccination.
That's really fascinating and important findings. Can you tell me a little bit about HPV vaccination and people assigned male sex at birth?
So HPV vaccination is for everyone. HPV vaccination should be given to all children between the ages of 9 and 12, and they should receive 2 doses prior to their 13th birthday. And this does not matter what the gender is because HPV is a pretty bad actor. It not only causes cervical cancer in people who have a cervix, but it also causes anal cancer. It causes cancers of the tongue and tonsils, and it can cause vaginal, vulvar, and penile cancers. So everyone can benefit from this vaccine.
And if you don't get it at age 13, up to what age can we have the HPV vaccination?
So the vaccine is most effective at the recommended age of 9 to 12. It's still recommended between 13 and 26, but essentially with every year someone gets older, the effectiveness goes down because HPV is a ubiquitous virus, and this is a preventative vaccine. So if someone is exposed to HPV before they get their vaccine, it has been shown to not be effective. Vaccination is optional for people ages 27 to 45, but because the rate of previous infection is so high, it's shared decision-making, not a strong recommendation because it's not expected to be effective or cost-effective on a population level.
Thank you. Those are really important points for clinicians and patients as well. So let's pivot to cervical cancer screening. So for people who have a cervix, what are the screening guidelines right now?
All right. So for people who have a cervix, and this is women who have not undergone hysterectomy or those assigned female at birth who have not undergone hysterectomy, everyone can benefit from screening. Currently, there are 2 sets of guidelines. There's guidelines from the U.S. Preventive Services Task Force, which are currently under revision, and newer guidelines released in 2020 by the American Cancer Society. HPV testing is really the cornerstone across the guidelines. And this is because we know that HPV causes cervical cancer. We know that the longer an HPV infection has been present, the higher the risk for developing cervical cancer and precancer. Knowing whether someone is HPV positive and whether they've been repeatedly HPV positive or repeatedly HPV negative is the best way to know someone's future risk of developing cervical precancer and cancer. So all the guidelines agree that between the ages of 30 and 65, everyone with a cervix should be screened at 5-year intervals. There are patients who are high risk, which we'll talk about in a bit, who need to be screened more often. But for someone who is average risk, meaning they don't have a history of abnormals or cervical cancer or immunosuppression, screening every 5 years with an HPV test, with or without a concurrent pap test, is really the way to go. Between the ages of 21 and 29, that's where the USPSTF and American Cancer Society guidelines differ slightly. The U.S. Preventive Services Task Force says to begin at 21 and screen with pap testing every 3 years until you get to the age of 30. And the American Cancer Society says to start with HPV testing and begin at 25 and just keep going every 5 years. Essentially, that's going to be about the same because an HPV test, the reason it's recommended is because it will pick up 90% of your precancers and cancers every single time you screen. Whereas the pap test only picks up 50 to 70% every time you screen. So you have to do it more to make sure you don't miss stuff because you know that you've missed up to half of the things that were there every time you screened. So between 21 and 29, you could either screen 3 times with the pap test or once with the HPV test to give you the same result.
What I hear frequently as an obstetrician gynecologist is we have to get patients to come in every year. Now, is pap testing that's every 5 years or HPV testing that's every 5 years, is that going to deter people from coming to their doctor for a primary care visit yearly?
So there are so many reasons to come in for the primary care visit that cervical cancer screening should be one of many. And it's also important to assess people for whether they need screening, because if someone has a history of being HPV positive or have had an abnormal pap test or have been treated for a precancer or have immunosuppression, they're going to need to be screened more often. And that's about 20% of patients. So 1 out of 5 patients won't qualify for the 5-year interval. So it is important for people to come in not just for a pap test, but also for all of the myriad of other primary care needs that often people probably don't even realize they need before they show up at the doctor's office.
And can you clarify the immunosuppression? So in terms of the high risk category of patients that may need decreased screening intervals, can you expound on that, please?
Yeah, so the people who need screening more often are people who had a abnormal or positive HPV test or abnormal pap test in the recent past, people who've had cervical cancer diagnosis ever in their life, which is a small number of people, or people who've had a diagnosis of precancer, sometimes called cervical intraepithelial neoplasia, grade 2 or 3, or with older pathology terminology called moderate or severe dysplasia. Those people remain at elevated risk of cervical cancer for at least 25 years and probably for their whole lives. So they will need more frequent screening, usually at about 3-year intervals for at least through the age of 65 and can continue for as long as they remain in good health. And then the immunosuppressed group, that will include people with HIV, people with any sort of other inherited immunosuppressive condition, as well as people with organ transplants and people who are on some of the heavier duty biologics for something like rheumatoid arthritis, where their immune system is suppressed.
Are there some important points to make about health inequities with respect to cervical cancer screening?
Yes, cervical cancer screening is essentially a disease of disparities because we know how to prevent it. If we get everybody vaccinated and we screen everybody equitably, nobody will have cervical cancer, or almost nobody. There will probably be a case that escapes here or there, or is one of the extraordinarily rare cases that's not HPV related, or is a metastasis from some other cancer site. But the run-of-the-mill regular cervical cancer will just disappear. And so right now, when we see cervical cancer, over 50% of cases are in people who were either never screened or screened way more than 5 years ago. 30% are in people who had an abnormal screening test and were not able to get follow-up. And then the remainder are in people who either screening missed it or the follow-up missed it. But we really can prevent it. And, we see decreased screening associated with individual level lack of insurance or poverty, as well as county level lack of insurance or poverty. We see it with language barriers. We see race and ethnicity disparities. So if everybody has access to the care that they need, then we will see it disappear.
Yeah, thank you so much for underscoring that. Access has so many dimensions, not just health insurance coverage or ability to go to a clinic, but living in more rural spaces, having experience of discrimination, racism with the healthcare system, and just the experience of distrust of the medical care system and all of the biases and social and economic determinants of health all play out in the cervical cancer screening space. And I so agree with you that we can stomp out cervical cancer. It's going to be an all hands on deck approach needed. Now, self-sampling, is that on the horizon?
So self-sampling shows great promise for cervical cancer screening. Essentially, this is where you would either mail home or your patient is in the clinic for another reason, and you can just send them into the bathroom with a little Q-tip swab to self-swab their vagina, which we're already doing for vaginitis and group B strep. And patients do it very well. They're very familiar with it. And then you can test it for HPV. So self-sampling has already been approved for populations that aren't participating in screening in some other countries like the UK and Australia. And it is up for FDA approval here, but has not received FDA approval yet. But there are many people who are looking forward to self-sampling being approved because it should decrease access to screening. That being said, if you test HPV positive, you still need to go and get follow-up testing. So if you are bringing HPV self-swabbing to an area that doesn't have someone to do a follow-up Pap test or colposcopy, that will not be very helpful. Because if someone is HPV positive, you're only going to prevent cervical cancer if you do the follow-up testing and then treat them for the precancer.
Are there any other things you'd like to add for our listeners?
Yes, I wanted to talk about the management guidelines because there is a new set of guidelines for managing abnormal HPV and Pap tests that was released in a very difficult time to have a brand new paradigm shifting, incredibly exciting scientific advancement, which was April 2020. So I think that possibly some of our listeners might not be so aware of these guidelines because they were overshadowed by COVID. Essentially, they're very exciting because instead of just managing your patients based on their HPV and Pap test results, we're actually managing them on their risk of precancer. So what was done was a huge 15-year follow-up study on over 1.5 million women who were patients in Kaiser Permanente, Northern California. And then those data were validated in the CDC Breast and Cervical Cancer Early Detection Program to ensure that all of the estimates that we were finding were applicable to safety net settings of care as well. Essentially, the guidelines, when you plug in your patient's Pap and HPV test result and then their history of maybe they were HPV positive, maybe they were HPV negative, maybe they were previously treated for precancer, you will be able to know to a decimal point what their risk of having precancer is today and over the next 5 years. And so what that allows us to do is really personalize care. So if someone's risk of having precancer today is 4% or higher, then we need to do something with them right now. They either need to go to colposcopy, or if their risk is really high, like they have a high-grade Pap test and maybe they're HPV 16 positive, which is the worst HPV type, it might actually be recommended for them to go straight to have a procedure to remove the abnormal cells without even first having to bother with a colposcopy and biopsy because it's so likely that you're going to find a precancer there that needs to be treated. Conversely, our patients who are lower risk, maybe they have just a low-grade Pap or abnormality, and their last HPV test was negative, so you know the HPV infection hasn't been there very long, those patients can be followed up in a year instead of having to go to a colposcopy and get a biopsy that wouldn't find anything. So it really allows us to focus care on the patients at highest risk and not do things to our patients at lower risk who don't need to have stuff done to them. And what this means in practice when clinicians start implementing risk-based screening, which means your patients who've had prior positive HPV tests are going to screen more often, and those who've always been negative are going to screen less often, and we're going to do colposcopy on the high-risk patients, but we're going to retest in a year the patients who are a little bit lower risk. What we're going to start to see in our clinical practice is more abnormals because we're doing less unnecessary testing. So what that's going to feel like in practice is you're not going to see your patients with negative test results very often. And so you're going to see a lot more patients with positive test results, which is going to feel like, oh my gosh, why am I getting all these abnormal results? And what that actually means is it's working because we're doing more to the people who need it and doing less to the people who don't. Similarly, for people who are doing colposcopy, the biopsies for patients with the abnormal results, the guidelines will shape your colposcopy population so that more of the patients will have precancer and need treatment because we're trying to keep the patients who don't have precancer from coming in and getting biopsies if they don't need them. So what this is going to feel like in clinical practice is more abnormalities, and among the people with abnormalities, more precancers because we're trying to shift our care. We're focusing it on the tip of the iceberg or the top of the mountain and reducing unnecessary tests and procedures in people at lower risk.
Well, thank you so much, Dr. Perkins. That was really helpful for all clinicians who screen for cervical cancer and who administer the HPV vaccination. I'd like to thank you very much for joining us today with your very insightful comments about this important topic of cervical cancer screening and HPV vaccination. I am Dr. Melissa Simon, and I've been speaking with Dr. Rebecca Perkins about cervical cancer screening. You can find a link to the paper in this episode's description. To follow this and other JAMA Network podcasts and interviews, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at the JAMA Network. Thanks so much for listening.